Good afternoon. I was talking to you for last three times, I mean, on different days about tuberculosis, past, present, and future. So I'll be concluding today. Maybe I'll take 5-7 minutes. Then I will like to interact you people all. When I'll interact, you have to everyone should on their videos. So, what I talked in those 3 days about tuberculosis, past, present, and future. I talked about something regarding diagnosis, what was in the past, present, and future, and then something regarding treatment. So as far as let me conclude today. As far as diagnosis of TB, there has been a lot of, I'm repeating this slide because there has been change in the definition in recent times, especially in case definition that there are two types of tuberculosis. I have already talked to you, microbiologically confirmed and clinically diagnosed. Now, if you are diagnosing a TB, you should write like this. Are you seeing, suppose I see a case of pulmonary tuberculosis whose gene experts is showing MTB or sputum for AFB is showing AFB is positive, then I'll write, and gene expert also shows that that there is no rifampicin resistance. So in my prescription, I would like to write pulmonary tuberculosis, microbiologically confirmed, DSTB. That is what should be the complete diagnosis. Or rest, if it is not microbiologically confirmed, I have already told you that either confirmed by phenotypic, like for sputum for AFB, anything for AFB is positive, or culture is positive for microbiology, or the molecular methods are positive. Then it will become a microbiologically. If this is not, it will be as a clinically. I'll repeat one more example. When I say somebody had a lymph node, you did FNAC. If the diagnosis is proven simply by seeing those cells, fine needle aspiration cytology, then you will write tubercular lymphadenitis, clinically diagnosed. And since it is clinically diagnosed, we don't know whether it is a drug sensitive or drug resistant. And suppose with that FNAC material, you subjected to smear for AFB, or you subjected to gene expert. If they are positive, depending upon the presence or absence of rifampicin resistance, same tubercular lymphadenitis, you will write diagnosis TB lymph node lymphadenitis, microbiological proven, DSTB or DRTB, whatever you write to write. If there is a rifampicin sensitive, you'll write DS, drug sensitive. If it is rifampicin, you'll write DRTB. That is how today diagnosis should be written in the light of these changes. And of course, pulmonary and extrapulmonary remain. And only one more change I discussed with you. In our time, it was a relapse. Now, relapse word has been replaced with a recurrent. Relapse means, let me repeat again, if anybody has been treated for tuberculosis adequately, has been declared cured or treatment completed, and if he gets the disease again, that was the definition of relapse. And the same thing is true for recurrence. Now, since name I changed, otherwise definitions. So that is the change as far as diagnosis of tuberculosis nomenclature is concerned. And you know that I'll not go, we have all sorts of tests now. Initially starting from X-ray, going up to now up to gene sequencing, it can come there. Yeah, as you see that microbiological test like smear, CVNAT, your TrueNAT, culture, all these are microbiological tests. Supportive tests like X-ray, TST, IGRA, cytology, I said, this is supportive test. Even histopathology is a supportive test. It is not a microbiological test. And then drug susceptibility test can be done by CVNAT or TrueNAT, LPA, 1, 2, whole genome sequencing is coming up. That is what, and growth-based test which can tell about drug susceptibility, their culture. So this is what type of diagnostic tools we have to diagnose tuberculosis, so that you can write the complete. As far as treatment of tuberculosis, there has been a lot of change. You have seen pre-chemotherapeutic era, there were no drugs, only sanatorium. Then drugs started coming. And then after that, now we have full-fledged drugs. And now we have treatment. Currently, we have treatment for, these are the 5 regimens which are involved. One is for drug-sensitive tuberculosis. Whether it is pulmonary, extrapulmonary, it remains the same. You will start with the 4 drug and then end up with you start with the 2 drug and for 2 months, 4 drug for 2 months, and then 3 drug for 4. That is the standard treatment in India for all drug susceptible tuberculosis. Whether it is a new case, whether it is a retreatment case, provided it is a drug susceptible, or so you have the 1 regimen. Then we have then we have 4 regimens for drug-resistant TB. If drug-resistant TB is like H monopoly, isoniazid resistance, then the regimen, I already told you that you replace isoniazid with levofloxacin for 6 to 9 months. Then for MDR TB, we have a shorter regimen for 9 to 11 months, and all over a longer regimen for 18 to 20 months. And a new regimen like BPAL is used in India in some of the districts. This is for 6 to 9 months. So that is what we have in the armamentarium of the treatment. So this we have already dealt, but today I have concluded. And before I say, come to the interactive session, my journey, we have many times I might have shown my journey. First book I wrote, it took about 6-7 years. You should also that how to write books, and that was Atlas, and it was a very difficult book, but still it is running, and it is going to be revised this year. Atlas, they have already demanded probably that you have to revise, so we are revising it. Then we have 3 or 4 books on tuberculosis, like Manual of Tuberculosis, Clinical Tuberculosis, a pure exclusive book I written on MDR and XDR tuberculosis in India way back in 14-15. Then in 2018-19, we wrote an adverse drug reactions in TB treatment. All has been compiled together. Then I have 100 cases in pulmonary medicine. Then we have clinical allergy. And even this book, clinical allergy, a multi-author book, all the who's who in India, they wrote in this book. And this book is also has been revised in 2024. And X-ray, that my latest book on chest X-ray, manual of chest region 2 volumes, and we have a lot of YouTube, so I'll not repeat. As you know, for PGs, you must see that there's a history, how to take history, auscultation, one of the lecture which I took in AIMS Patna, then my X-ray lecture is very popular. Many people have seen it. So you can benefit out of it. Now I finished all this lecture of past, present, and future. Now I'll go for interactive. I would like that maybe for maybe for half an hour or less than that. If you have any query, what I have taught to you, because I have not taught you in a great detail, because time would not permit me. So what you can do now, we can interact. And now I wish that before I say, where is the interactive session? Yeah, just hold on. I had some. So now we can finish it up. I had one slide. I was trying to search. I don't know. Yes, this is the slide. Now we'll go for, as I said, this is an interactive session, and now I wish that every one of you should on your videos. Please on your videos. या जो सवाल करे वो करे. If you have now I have finished my this lecture, tuberculosis past and present. Now I wish that you have something in your mind. You can ask me, I'll try to answer. So have a courage, put some questions, because this will be interactive session.
Good afternoon, sir.
Okay, Uruj, come on.
Sir, can you please elaborate about the role of steroids in TB treatment?
Well, I think, Uruj, you put a very interesting question. And steroids are used many times in tuberculosis. Facts, what you have to remember. I'll start saying like this. What I was taught way back in 70s and 80s, my mentor has been very good. So he used to talk to us about what could be the role of steroids in tuberculosis. And the same way I have written in my all the books of tuberculosis, this is a chapter. So he used to tell us at that time there are some absolute indication and there are some relative indication. I'm talking of 80s, 70s and 80s. So absolute indication, there are 2-3 things he used to tell. One thing, and they are valid even today. Like say, if tuberculosis patient is a very sick, he is in terminal, any type of tuberculosis. If he is in terminal condition, a pre-terminal condition, because you will prescribe anti-TB drugs. So to gain some time, anti-TB drugs will act, it will take some time to act. In the meantime, you wanted to save the life, to save the terminal patients of tuberculosis. Along with anti-TB drug, you will also prescribe, and this was the highest dose, means 1 milligram per kg. And we have saved like this many patients. So many times I see in the wards, there are very sick patients, terminal stages. Do you think that only ATT is going to save the life? No, ATT will take some time. So what he used to say, I still say those words, you want to buy some time so that the anti-TB drug start working. So I have saved with this principle many. And then he used to talk the relative indication, means you may or may not. And another absolute indication at that time was TBM, tuberculosis meningitis. Pericardial effusion is, if I am talking today, is another thing where there is an absolute indication. So 3 things. Absolutely indicated means pre-terminal, terminal patient of tuberculosis who are very sick. You want to buy some time, then TBM, and then pericardial effusion. And rest are relative indications, like pleural effusion, you may not use. Pleural effusion, what evidence says that it may not prevent the fibrosis, but if the fluid is, moderate to massive, you want rapid absorption of the fluid. So along with steroids, you can use it. And then there are many more relative. If you read my book, and I have written even some of the cases, I have given the very massive TB lymph nodes undergoing necrosis and creating lot of symptoms. If they are not responding, you may use sometime steroids, 4 to 6 weeks of steroid, and I have seen many. So that is how the role of steroid is defined. But one more thing, whenever you talk of steroids, always think of without ATT, without adequate coverage of bacteria, you cannot. It's a crime to use steroids. So you should know that when to use, and when there is a relative indication, doses are relatively less. In absolute indication, doses are high. That is how we are using it, and now literature also saying the same. I hope I am clear. Like today, I saw one case of diffusion which was quite, I think, Uruz, you got reviewed. My feeling was it was a massive pleural effusion. If it is tuberculosis, probably steroid may help in rapid absorption of the fluid.
Yes, sir.
That's okay?
Yes, sir. Thank you, sir.
Okay. Anybody else?
Good afternoon, sir.
Good afternoon, Ilmi.
Sir, my question is, how do we manage ATT-induced hepatitis?
That's again a very common, I think, situation. You know, when you use ATT, whether it is a drug sensitive or drug, majority of the patients are drug sensitive tuberculosis, right? And when you use in a drug sensitive tuberculosis, what happens after a few weeks, patient develops symptoms. That's why you suspect hepatotoxicity. Sometimes symptom may not be there. So what rule says today, if you are suspecting hepatotoxicity and if the enzymes are raised less than 5 times, that is one. If there is hardly any symptom, two, because sometimes you do LFT in between, and three, serum bilirubin is not raised. So he is asymptomatic as far as liver concerned. Enzymes are raised. Initially it was 3 times, now people say 5 times. And he has no symptoms, serum bilirubin is normal. There is no need not to stop. But in majority of the patient, what we see that they are symptomatic. And the first symptom is probably loss of appetite, nausea, vomiting. Then you suspect, get LFT done. If the enzymes are raised by more than 3 times, our serum bilirubin is raised more than normal, our patient is highly symptomatic. In these situations, what we do, usually we stop the therapy for about 5 to 7 days. And then as immediately when you stop the therapy, it is a drug-induced hepatitis. Let me say symptoms drastically improve. So it's very important to recognize these. Maybe after 7 to 10 days, you repeat the LFT. When patient improves, everything comes out to be normal. Then you have got, there are 2 recommendations. One is the how to suppose patient has improved. The another way could be that if patient has improved and LFT has come out to be normal, now you wanted to reintroduce the drug. What should be the sequence of reintroduction? That is the little difference in two. One is the American Thoracic Society recommendation. Another is British Thoracic Society. In American, what in Americans do in their guidelines, the reintroduction sequence, they say first thing is to be reintroduced rifampicin, then you introduce INH, and then you introduce ethambutol. You can also introduce paracetamol. That is one sequence. But British guidelines, they always say, what we follow is usually British guidelines. That stop the drug, repeat the LFT, if everything is normal, you may reintroduce the drug, and the reintroduction is in terms of isoniazid first, ethambutol. You can start like this, then you may add rifampicin if it tolerates these two drugs, and pyrazinamide sometimes can be added, but usually up to a patient has tolerated up to rifampicin, you may try. Many patients, they retolerate. It is not always the drug. There are many more issues, but usually what happens in such type of scenario that INH and ethambutol and rifampicin up to this time they tolerate. When you introduce pyrazinamide, symptom may reappear, so you have to go for 3 drugs. So that is what is the British way of what we also follow. If you find Western textbook, INH, they say American, especially American, they say INH is a very hepatotoxic. In India, what we have felt, INH is very safe. In my whole life of about 48 years, I have just reported 3 isoniazid, 3 cases of isoniazid. So in India, what we see in the case of hepatitis or in hepatic toxicity, INH ethambutol is very well tolerated. Rifampicin also tolerate. But one more idea that suppose if you are not able to resume all the drugs, say rifampicin and pyrazinamide, when I say all the drug means rifampicin and pyrazinamide, then regimen not is a short term. Suppose you are using INH, ethambutol only, even rifampicin patient is not tolerating, then regimen should be at least for a year, not less than that. And if suppose you are using INH, ethambutol and rifampicin, then the regimen is for 9 months, not for 6 months. So that point always should be kept in mind. That what drugs patient has retolerated and duration also had to be adjusted accordingly. And then in the liver, another thing what we say, suppose somebody is suffering from TBM, a very serious condition, where probably you cannot stop all the drugs. So there, what you do, don't stop all the drug in this scenario, continue at least with some of the drugs who are hepatosafe. And most hepatic safe drugs to our understanding is isoniazid, ethambutol. Even in this scenario, you may use injectables, although injectables are not used in India. But if you want to have some drug, you may use the injectable for some time. And even another drugs are required. You may think of fluoroquinolone, you may think of cycloserine. But usually, especially, this is the condition where patient is very sick, he requires drug, and those scenarios, this is the thinking today going on. But in majority of the hepatic toxicity, many times we have, if disease is not very severe, there is no fun to take risk. For 7-8 days, you may stop the treatment and then restart the treatment, as I said in the sequence. I hope that's clear to you.
Ji, sir.
Anything else?
Good afternoon, sir.
Yes, Samarth, tell me.
Sir, can you please elaborate on how to treat TB in pregnancy?
Well, very good question, I must say. TB in pregnancy, today, as you know, there are most common disease is drug sensitive. You must understand in your day-to-day clinical practice, you find a drug sensitivity. 97% patients are drug sensitive. So that you must know. About the drug resistance, there are guidelines. I'll give you some hint. Drug sensitive TB, most of the drug, what we see that, especially the gynecologist, when we write prescription and the day pregnancy develops, many of the gynecologists, they try to stop the therapy, but that's not proper. In pregnancy, at least isoniazid is safe, ethambutol is safe, even rifampicin is safe, even pyrazinamide can be safe. Depending upon which the pregnancy is processed pregnancy. But what I have seen that we use at least INH, ethambutol and rifampicin, they tolerate well. And there is no effect on children. Only thing that what should be avoided is the injectables. Injectables, they cross and they produce deafness in the child. So injectables, especially in the first trimester, they are not used in any, after the first trimester, if you are very, the other drugs are not available, sometimes you may use. But even pyrazinamide is not so bad. So even if you think that tolerating, no issue, even pyrazinamide. So hardly for drug-sensitive TB, hardly any change. Only to be safe side, sometimes we avoid pyrazinamide. As far as drug-resistant TB is concerned, every time it has to be seen because at least 2-3 drugs which is create a problem may create is like ethionamide is a drug which is a teratogenic drug. So and there are guidelines if pregnancy is less than 20 weeks, you may advise MTP, and suppose patient is not willing, still you have to treat. But ideally is MTP, and then after MTP you may continue shorter or longer regimen depending upon. There are certain modifications are done, and that you can read guidelines for the drug-resistant TB. There's a beautiful guideline how the DRTB should be managed in pregnancy. Anything else, Samarth, you want?
Thank you, sir.
Good afternoon, sir.
Good afternoon.
Sir, how to approach in diabetic patients the treatment regarding?
Okay, I think that's a very common problem. When I say common problem, means in India, we are a capital of diabetes, we are a capital of TB both. So many patients, they are together. And I used to say that if you are having two problems and if you treat only one, probably you will not be successful. So first thing that diabetes should be detected in TB, in every TB patients. And if it is there, it should be properly treated. So I'm not talking about treatment of diabetes. I'm talking about how the treatment of what problems it can create. Diabetes, usually what I see in India, they are not very adequately controlled. So one rule that if before I go to, I would quote an example. I was referred a patient when I was in KGMC. One of the patients of tuberculosis, he was getting a proper, some doctor prescribed him proper treatment, proper doses. He was compliant also, but he was not responding. So there are many there are many reasons why a person of TB do not respond. One of the reason may be the hidden diabetes. So when that patient came to us and we got blood sugar done, fasting PP was around 500. And I know that why he is not responding, because his diabetes was undetected and was not treated. So same drug, when diabetes was given anti-diabetic drug and same drug, he responded. So my message is, in every patient of tuberculosis, you must try to know whether he has a diabetes or not. That is one. If he has diabetes, effective treatment of diabetes is must. That is one very important thing. I say to my patient, because I usually don't treat diabetes, I send to some good physician or diabetologist. Because I know I will be not successful if diabetes will not be controlled. So I wish that his diabetes must be fully controlled. So, and when both the diseases are controlled, duration remains the same. But unfortunately, in India, diabetes is hardly under control. So many times what you have to prolong the therapy. And when I stop the treatment of patients of TB who has diabetes also, what I say I would like to repeat in front of. I say I have treated you for tuberculosis. Your treatment is over. But believe me that you are permanently going to control the diabetes. The day your diabetes is remained uncontrolled for 1 to 2 months, you will get the disease and you will get TB again and you will come. So relapses are very common in this scenario. So one has to very strict advise all your patients to undergo very regular checkup for diabetes, regular treatment for diabetes. Then these regimens, what we say, 6 months, 8 months, 9 months, depending upon, then they are, otherwise, sometimes we have to prolong the therapy. But message is very clear. If there are two diseases, both the disease has to be adequately treated. If you are treating one, you are likely to be unsuccessful. I hope I am clear.
Yes, sir. Thank you, sir.
Anything else I can do for you?
So can you please tell about the management of paradoxical reaction during ATT treatment?
Paradoxical reaction. Yes, paradoxical reaction, actually, people say that it is more common in HIV and tuberculosis. But even before HIV, paradoxical reactions were known. What is paradoxical? Paradoxical reaction means, it is also known as iris, immune reconstitution syndrome. So what happens when you give ATT or when you give, suppose, HIV and TB both, when you give ART, their immunity improves. So sometimes the lesion gets increased. So what is paradoxical reaction? Whether the lesion gets increased, new lesion may develop, and even lymph node size may enlarge. There may be coagulation. So all sorts of things are possible. So in iris, usually if he is not very highly symptomatic, you need not to add any treatment. But if the iris is there and he is a highly symptomatic, sometimes fever and other issues, then a small course of steroids sometimes are indicated. Especially I see the lymph node where it is under paradoxical reaction. Sometimes I have seen that adding steroids may be quite helpful. One more thing about the iris. There's a lot of misdiagnosis of drug-resistant TB in iris. Because, if somebody you are treating tuberculosis and he gets increased lesions, new lesions, then chances of drug resistance is also there. So you have to be very clear. If it is not so you have to investigate the patient. Is it not a drug-resistant TB? Now it is possible very easily. So if it is not drug-resistant, it is because of the paradoxical reaction. You may continue the same treatment and patient usually respond. In some of the very sick patients, you may think of adding steroids for 2 to 4 weeks. That's all how the for example, I'll to tell you, I saw a young lady about 12, 13 years of age. And initially, first she was treated from the pediatrician. The first lesion, she developed lymph node in the axilla. After some time, she developed lymph nodes in the mediastinum. After some time, while she was on a drug-sensitive treatment, because lymph node axilla was, the gene expert was done and it showed drug-sensitive TB. So after some time, pediatrician again referred to me that she had developed blurring of vision, nausea, vomiting. So we have excluded drug intolerance. So we got then it was seen by some neurologist. She had a seizure also. She has to be admitted. When CT head was done, she developed tuberculoma. That is how the multiple lesions develop in paradoxical. And believe me, this young girl has treated by me also along with pediatrician and neurologist. Only same that we have not changed the regimen because there has been no evidence of drug resistance anyway. And the same treatment, we treated for little 3 months more because she has in brain also tuberculoma. So probably we have to treat her for about a year. And after a year, everything has subsided. So that is a typically I recently saw. I think some of you have made record of this very young, very young child. And so iris, what I'm trying to say, iris is a not very uncommon, and especially in the lymph node, it is seen in about 30% of cases. Lymph node size may increase, new lymph nodes may appear, lesion on other sites may appear. They all have been possible, and we have treated all patients like this, and this is what you could follow. Any other question? Ilma, koi hai aur koi?
Yes, sir.
Do you want to have some question?
Yes, sir.
What?
Sir, how do we follow a patient after completion of the treatment?
That's also a very important question. The answer has two components. One is that during treatment, how you follow up. You know that if follow-up is done by clinically, by seeing the patient, that really when you start treatment, you follow the patient by clinical, his appetite improves, weight gains, he gains weight, he or she weight gains. It means he's improving. Then another method you adopt is you follow with the X-ray. X-ray also you see if it is improving, it's okay. But the best method to follow up is a microbiological. Microbiology, one should remember, it is only the phenotypic type, either smear for AFB or culture. Genotypic methods are not used for follow-up. As you know, that gene expert is not used to see the follow-up of the patient. So it is you just do smear. If need be, do a culture for MTB, and that is how it is followed. So follow-up is done by all the three methods: clinical, radiological, microbiological, means bacteriological. But if you say that, what is the gold standard? Gold standard, no doubt, is bacteriology. But otherwise, he may very clearly tell. This is the follow-up during treatment. Now, when I was doing MD, my boss was very perfect, I must say. He used to follow up. He has told us, when you finish your treatment, you must follow up these patients. So in my PG days, we used to follow patients for 5 years. Every 6 months, 3 months, whenever he gets. So whenever I stop the treatment, what I say that please come for follow-up every 6 months. Earlier you may come if you develop symptoms. So you have to do follow-up at least for 2 years. And now I'm happy that even in the program, National TB Elimination Program, initially follow-up was not there after treatment is stopped. During treatment, follow-up is still there. But now when treatment is stopped, follow-up has been advised. And you know that 2-year follow-up of all patients who have completed the treatment of anti-TB drugs, whether it is drug sensitive, drug resistant, every 6 months you have to follow up. And idea of follow-up is that you detect if something, 5 to 10% patient, they get recurrence. So to detect early recurrence, if you do a regular follow-up, and one more sentence I tell to my patient, 6 months if you don't have any symptom, मरीज बहुत घबरा कहता है साहब कोई तकलीफ तो भी आएंगे, हमने कहा तब भी आइएगा, follow-up जरूरी है, और if you develop some symptoms, then you can come earlier. So follow-up is very important, even after the treatment. There's a lot of sequelae. You must have heard post-TB lung disease. There's a lot of sequelae, lot of fibrosis, lot of bronchiectatic changes. Even cavity sometimes by open heel method, it remains. So it can create a lot of complications. That's why the follow-up is also of every TB patient is very important. Okay, Ilma, I hope I'm clear. I'm happy that today PU people are asking a question and interacting. Huh? Any other question? Oh, yes.
Can you please tell how to treat when patient is on ATT and he presents with dermal complications?
Present with?
Dermal complications like maculopapular rash.
Okay, very good. RAS is also very important adverse drug reaction. And what happens if somebody, I am putting any treatment and he or she developed rashes, first action, you stop all the drug. Because you don't know which drug, any drug can cause rashes. So first, the interaction should be, if somebody have rashes, you stop all the drugs for 7 to 10 days. Give anti-allergic. If rashes are very severe, some of the drug can produce a very severe rashes. You may use sometimes steroid for some days. So, but then as rashes disappears, try to use drugs one by one. And initially, when you retry these drugs, risk is always there that rashes will develop again. So suppose you start with isoniazid. First, you may start with 100 milligram of isoniazid. If it tolerates, you can go for 300. Then add ethambutol. Again, lower doses, because any drug can have rashes. And then you start with rifampicin. Again, you may start for 150, go 300, 450, 1 or 2 days interval. Like that, you have to retest. You have to challenge these drugs, and whatever drug he tolerates, that you have to continue. Sometimes it is very difficult to manage rashes. At least I managed one doctor who had rashes with all the drugs. Probably I managed simply only with INH and maybe ethambutol. That he was able to tolerate. But then, depending upon the drug, what you have been able to restart, the duration is also very important. If you are not using rifampicin, if you have not been able to use rifampicin and pyrazinamide, it will never be a shorter regimen. It will be a longer regimen, and treatment may go for 1 to 2 years. That's the message. Okay, Samarth?
Ji, sir. Thank you, sir.
If there is no more questions, you have another thing. You people have not come out how these drugs are used in a renal, in kidney. Everybody can on your videos. I will tell you. इल्मा अपना वीडियो ऑन कर दो. देखिए जो ड्रग जो रीनल डिपेंडिंग अपॉन द यूरिया क्रेटिनिन or creatinine clearance, as far as drug sensitive, which is very common again, one isoniazid and rifampicin needs no change. Similar doses. Only change is required. First, ethambutol. You have to use probably dose maybe thrice weekly. And even pyrazinamide is also given thrice weekly. That is what is changed in the, and in renal toxicity, then of course the injectables are contraindicated. Injectables are hardly used. In a second line drug, second line drug, again, what you use is isoniazid, moxifloxacin, ethionamide, clofazimine. They need no adjustment. And if the creatinine clearance is less than 30%, then what are the drugs which need adjustment, like pyrazinamide, ethambutol, I have told, like drug sensitive, even levofloxacin, sometimes you have, bedaquiline, it has not effect, so there is no change in bedaquiline. And amikacin, I said, if you are using 3 times, you cannot use more than 3 times a week. And cycloserine also, its dose is reduced, and past dose is also reduced. That is how you can read PMDT guideline, very clearly written that what to do. But most of the cases are drug sensitive TB. So only in drug sensitive TB, only 2 drugs would require dose adjustment is ethambutol and pyrazinamide. INH, rifampicin needs no drug readjustment. So I think if there is no more question, let me sum up my whole presentation. And you have in my presentation what I have told you, that the tuberculosis is common in India. It is in your day-to-day clinical practice. You have to come across such type of cases. And why I have told you the past also, because many patients comes with the 20, 30 years back, then you should know ideally what was the treatment in the past. So that it becomes very important. And I think with this, I would like to, if you have no more questions, I'd like to end. And I hope I'm going to put this, these all, I think there has been, this is the 4th lecture of this series. Ilma? Ilma?
Ji, sir. This
ये
is the
चौथा
4th
lecture
lecture.
हुआ ना? हैं?
Ji, sir. Ji, sir.
So as I have discussed with you that please make sure that these presentations are edited,
Ji, sir.
and so it is not only you people can get help out of it. I think whole of the India may get help out of it. This is, I think, one of the very important lectures. So if you have no question, then I must say thank you to all. Today, at least I am very happy that you have been I purposefully put an interactive session. And always I say that whenever you attend, be attentive, and try to ask try to get clarification some of the questions in your mind. So if you have no question, then I'll stop this and thank you.